Can you make it full screen? Okay. Manish, till then I think you want to take any question. I think they're setting up. Okay. It's coming? Okay, sorry for that. So respected teachers, senior ophthalmologist, my dear friends. So I'm Dr. NIVEAN and I'm going to talk about the new innovation, the CMT Flex IOL, a new option for Aphakia. No financial interest in my presentation. As you all know, all inventions come with a question why, so did mine. We have seen here in this particular session that the various types of secondary IOL techniques, starting from the sutured technique, which is still the gold standard, which is tested for more than 4 decades. And then the Gabor-Chariot externalized the haptics, and then various modifications of these externalizations like the glued IOL technique, then the XNIC technique, and then the Yamane technique. But then thought, why not have a new design of an IOL for this type of aphakic patients? So that gave birth to the CMT Flex IOL, which is nothing but a single piece hydrophilic lens with a T-shaped haptic on either side. So these T-shaped haptics, when brought out of the sclerostomy, opens up and prevents the lens from falling back inside. So let me just go through a couple of surgical case scenarios to explain how it works. So here again you have a case of Aphakia, which was planned for a secondary IOL. As you all know from all the other previous speakers, 0-180 degree marking is a very, very important step for any secondary IOL. So here we make the 2 by 2.5 partial thickness scleral flaps with a crescent blade, and 1.5 millimeters away from the nimbus, I make a 23 gauge sclerostomy. So being hydrophilic, this lenses is a foldable lens, so it can be done through a clear corneal incision, as you can see here. So as you inject the lens, the T-shaped haptics has to come out first. So it's easy to grab it head on. So you have various parts. The neck can also be held, but ideally this place is easy because when it comes out of the sclerostomy, it actually bends forward. So it has less resistance when it comes out of the sclerostomy side. At this time, do not pull the lens because it's a single piece lens. So inject the remaining lens, leave the trailing haptic over the iris or at the wound. And once the lens is injected, then you slowly pull out, and you can see the pop of the T junction and it stays outside there. So just a small animation video clip to show how it works. It can work with any regular IOL cartridge, the foldable lens. So clear corneal incision, just a regular 2.8 millimeter incision, grab the head of it and then pull it out and it stays over the scleral flap. For the other side, we use the handshake technique. So you use specialized forceps called the grasping forceps and hold the arms of these forceps and exchange it to the other side. Being hydrophilic, again, it is less tissue forgiving and damaging, so you can maneuver it very well within the eye, and you can see the second haptic brought out and pops out. So once that is done, there is literally nothing else to be done, and if you get the 0-180 degree, there's not going to be any tilt. So once that is done, you can either glue the flaps, or you can suture the flaps, or you can even do cautery. This is day 1 post-operative pictures of the lens that you can see here, and this is 1 month post-operative pictures where you can see clear corneas, well centered. We also did studies on UBM and the OCT pictures over the sclera to just see long-term how the flaps and if any exposure of these haptics are going to be there. So then after getting this, we move on. You can actually combine with any challenging cases, like any of the secondary IOLs, like any trauma or any cases can be done. So the second case is one such case. It was a young patient who was on maximum glaucoma medication, long-term injury, aphakia. So it was planned for a trab with a secondary IOL implantation. So first the glaucoma surgeon went ahead and did the trab superiorly, as you can see here. Just going to rush through the video, mitomycin C. Let's see if I can find the PA and the absorbable sutures. So then again, now we make the flaps again 0-180 degrees is again very important here. And then a good anterior vitrectomy. I think for any secondary IOL, the key success is again having a good anterior vitrectomy. Make sure there is no any vitreous. And I always like to stain the vitreous with tricot for two reasons. One, you are able to see the vitreous. Second, some amount of the tricot crystals that go underneath prevents some amount of post-operative CME also. So these are the two specialized forceps, the grasping forceps, which has got the serrated edges, and the CMT flex forceps. So this thing being, because it's a hydrophilic material, the retina forceps sometimes with the sharp edges, when you hold these lenses, can bite into the material and chip away the material, and that can cause breakage of these lenses. So here again, you can choose a different site for injecting the lens. You can see the T-shaped haptic coming out first. Grab it. Again, just wait. Just inject the remaining of the lens. So once the lens is there inside, out of the cartridge, and then you gently pull it out. So the key here again in doing is, it has got a small learning curve for any of these procedures that we have to do. Just make sure you don't lose the grip on it. So here you can see it's there on both the sides. In this particular case, we had the sommering ring also to deal with. So as you all know, these are like calcified remnants of the cataract portion with the capsule, and sometimes it is not very easy to dislodge them or remove them with IA. So in this particular case, it was nice because we used this T-flex as a scaffold here, and just lowering your bottle height, we used the phacoemulsification to eat away the sommering ring, because sometimes we take a long time and struggle if you want to do it with an IA. So just make sure you don't lose any of the pieces behind, because so far everything else is done anteriorly itself. So once the sommering ring is cleared, there was some synechiae also that were there superiorly. This was because of the trauma. So all the synechiae were released, and that is why the pupil looks irregular. If you can see, it's not the decentration of the lens, it is because of the size of the pupil that is irregular, that is giving picture. So once all the synechiae were released, this is how the patient entered on table. This is post-op picture 1 week with a good filtering bleb. You can see the scar on the cornea, the trauma, the PI, and a well-centered IOL. And also for anterior segment surgeons also it can be done. I always think the biggest challenge is hypotony in any of these cases. So ideally having an AC maintainer is good, because we are surgeons more comfortable with using a trocar, but we can do it through the anterior approach. So but the principles again remain the same. This was a case which had an aphakia post small incision cataract surgery. You can see the sutures there, but you don't have to open up the wound. You can go to a fresh site after a good vitrectomy. Again emphasizing the point of having a good vitrectomy in any of these secondary IOL cases. So here advantage, that's why I'm not injecting the lens. So even if you lose the grip, you can always go and re-grasp it again. There's no hurry. Just make sure you feed it into the forceps and then inject the lens. So you had it inside the cartridge, so you don't have to worry about it falling back inside when you're doing this, isn't it? I usually prefer to hold the flap just to make sure, because there's always a tug there at the sclerostomy site because of these forceps, because these are 23 gauge forceps, and then it comes out. So others say the same thing. I'm just going to it. So at the end of this particular case, I just use tricot to check in the anterior chamber if there's any vitreous left. As you can see, so there's no harm in always checking to make sure everything is fine, and then using the glue. So there are complications related to this, like you can have the breakage of the haptics or slipping when you pull the other side, late dislocations, exposure under the sclera. But I think some of these complications are common for all secondary IOLs, and there is a learning curve. So it took a long journey of more than 6 years from the drawing board. And now I'm happy that more than 250 users across India have used it and also given their feedbacks about modifying the techniques. And these are some of the publications that we have in the various journals. And yes, maybe because of COVID, there was a delay in everything. So hopefully everything works out well, and this is our painted. So once again, thanks AOS, and a special thanks to Dr. Mani sir for having me here in this session on secondary IOLs. Thank you.